ACR 23, this is the Room Now daily recap. This is where the faculty gets together at the end of the day, pour a glass of wine, open a bottle of beer, and say, gee, let me tell you about what I saw today. I'm joined today by Dr. Robert Chao in Virginia, Sheila Reyes in the Philippines, Yuz Yusof, who's here in San Diego with me, as is Rachel Tate, and I'm Jack Cush. The rules here are each of us are going to give you our main thing that we want to talk about from today, and then after we've all gone around, we'll give you some quick hits to round out this session. Let's begin with Dr. Rachel Tate. Rachel, what did you see today that was great?
Hey guys, so I'm going to talk about abstract 0494, which was understanding inflammatory bowel disease in our SPA patients, non-radiographic AS and PSA patients. So this is a Spanish study. It looked at about 550 patients, majority of whom were actually men. But it's interesting, and why I like this study is because they checked a fecal calprotectin in patients prior to sending them on for evaluation for GI. Why this is important to me is because the reality of a fecal calprotectin, it's only a $20 test. So what they found is that if a rheumatologist checked this in these patients, these spondy patients, that 40% actually had an elevated FC level, which led to the diagnosis of inflammatory bowel disease in about 4% of these patients, an actual formal diagnosis. So it teaches me that we have a lot to learn about the breadth of these diseases and how they actually affect all of us.
So why were the SPA patients being sent for GI evaluations?
So if you kind of dig in a little bit deeper, they had some of them had a family history of inflammatory bowel disease, as well as a family history of inflammatory bowel disease. Some of them actually had symptoms at diagnosis of inflammatory nocturnal back pain, things like that. So it was kind of taking a deeper dive. It's actually the ISER cohort study. So it's really like 13 different hospitals in Spain. And I actually categorize this as an ACR best for us today.
So what do you guys think of that? Do you is this something rheumatologists should be worried about? Occult inflammatory bowel disease?
Yeah, I think so. I think, number one, hopefully it also decreases the wait time, right? Because, to visit any specialist, rheumatology, GI, usually the wait time I'm hearing from patients, months to half a year. But I'm also curious what the GI docs think, right? I think obviously refreshing for us in rheumatology. I hope to them it's not, oh my God, got another positive ANA referred to, rheumatology here. Hopefully it's not that. It does seem like the data is promising.
Stepping on toes. That's what we like to do with collaboration efforts, right?
Right.
Here's what do you think?
Rachel, I'm sorry. Did they give you like number needed to treat or anything, or number needed to harm, with that?
So it's a relatively small study, right? It's 550 patients. It's one cohort. It's one standardization of patients. But what it shows me is we need to be asking more questions. And also the price differential between an actual colonoscopy versus a fecal calprotectin or protectin, I'm never going to say that right, calprotectin is significant.
There was another abstract, a poster today, 0495, that also looked at a finding of occult IBD in SPA patients, over 500 patients, and they found that 47% of patients with PSA had a fecal calprotectin that was elevated, 53%. So the problem is calprotectin is an inflammatory marker in general in inflammatory diseases, so it may not be by itself indicative of IBD, but it's certainly a clue, right? But they did find on colonoscopy, I think the number was 4% of their patients, or a total of 23 patients who actually had IBD. So interesting stuff. Sheila, do you encounter this at all?
Yeah, I just wanted to add earlier, well, because of our resource limited setting, we don't usually request for fecal calprotectin left and right. It's still a bit pricey here in our country. And so we still go clinical. If a patient presents with GI symptoms in the background of inflammatory back pain and other spa features, then we do request for fecal calprotectin. But I think one of the things that we also should consider is that if we get patients with inflammatory back pain or a diagnosis of axSpA, we really need to ask questions, GI symptoms, apart from the fecal calprotectin, or requesting it, because we know that treatment also guides the symptomatology of these patients.
Okay. Sheila, I want you to speak up louder and speak into your microphone so that you're going to be at the same audio level as the rest of us. Let's go
All
on
right.
to our next presentation from Yuz Yusof.
Yep. So today I've been to a few SLE sessions, especially the treatment parts. So I'm just going to talk about the abstract 0781. As we all aware, the treatment, the paradigm, there's the paradigm shift in terms of treatment of lupus nephritis, and now the big topic is all about combination therapies from the onset, and also the use of low glucocorticoids. So I think that's what our targets. So this in this study, so what they've done is they compared patients who were on the standard of care arm of 4-RCT. So basically, these patients were treated with mycophenolates or cyclophosphamide, and in combination with either low-dose glucocorticoid, which is they define as up to 5 milligram per kilogram a day. So it's a 0.5, or the other one is up to 1 milligram kilogram per day. And then what they've done is they've compared in terms of the renal responses and also adverse events. And what they found that there was no significant difference in renal responses if you use the lower dose oral steroid versus a higher dose. And in fact, there were less side effects in the low dose steroid. So it looks like promising that we can use like oral low dose steroid from the outset for remission induction in lupus nephritis.
Yuz, can you put that in real terms that I can understand? Telling me 0.5, apples per oranges per kilogram or whatever. I don't understand. So we're talking about low dose being how much?
Yeah.
And versus standard dose of how much? Talk in prednisone doses.
Yeah, so basically, the dose is, for example, if it's your 60 kilogram, the higher dose is up to 60 milligram. So it's like 1 milligram per kilogram per day. Whether the lower dose is half of that, so basically, 30 milligram. So some people, if you have like 100 kilogram, then you can even start 100 milligram of steroid, isn't it? So it's quite high.
So is it where? So obviously, it's where you start. That doesn't matter, but does it have to do with how fast how long it takes to taper and where you end up? Is that as important?
Yeah, so that is important, and that is the one of the limitation that the authors acknowledge, because these 4 different trials have different protocols, so they are heterogeneous. So that's one of the limitation, because some trial, particularly the voclosporin one, they have really rapid reduction of steroids, whereas other trials were not. Yeah, so that's one of the limitation. Yeah.
Okay, that's interesting. I think when we're all dealing with nephritis, newly diagnosed nephritis, I do believe that every one of us are using high dose, are using milligram per kilogram doses to start. And if you listen to people who are lupus mavens like Dr. Yusof and others, they're telling us we need to get that down because that's where all the complications are and whatever. So how do the rest of you see this changing how you manage? Rachel, what would you do?
I mean, I think you said it best. This is an example of potential for what we can do in real world that gives us the confidence to actually do that. So the way I interpreted this particular study, and I actually tweeted about this too, is that it gives me the confidence to maybe not have to start as high But it really depends on the context of the patient. If it is an aggressive patient and their lupus nephritis is very active, I'm still going to kind of lean a little bit toward the opportunity of starting them at a higher dose, but maybe weaning them down faster.
That's the problem, isn't it? You know, so Sheila, you see a lot of lupus in the Philippines. You know, you see an acute lupus nephritis with hematuria and a bump in creatinine, and you find, you know, variable amounts of protein, and their lupus is otherwise active. Do you have the guts to give them, you know, 20, 30, 40 milligrams as opposed to 60, 80, or 100?
Well, honestly, I would still go with the high dose, especially because lupus patients, at least in my experience, they come and you see them at very high disease activity, and so you don't really have any room for giving low dose, especially if the delay in diagnosis has already been there. Systemic involvement is a lot, and I think what's important here is that we give the high dose, but if we can give it at a shorter duration and then taper off immediately, then I think that would be the best. So at the back of my mind, while we're talking right now, I'm reminded of Professor Michelle Petrie's reminder that steroids are poison, prednisone is bad. So if we could give it at the higher dose, if it could give it at a shorter duration, and then taper off immediately, that would be good. But of course, we know that it's not always like that in real life.
Dr. Chao, have you been modifying your steroid use in disease like this?
I think to answer your question to Sheila, do I have the guts? Before today, maybe, but from today's plenary session on ANCA vasculitis and that rapid taper actually being associated with worsening, everything, relapse disease for ANCA vasculitis, CK or ESRD, I should say. We were all excited, I think, because the Pexivast came out when I was in training, and we're like, okay, let's use a fast taper. Let's go for it. Prednisone, P is for poison. But then today, kind of that, and then, this, I don't know what to make of this, because I hope today it rings true, but, I don't know if there's still enough out there for me to treat these severely sick patients, with lower steroids, just yet, especially when they come in so sick in a hospital setting.
So is anybody going to be covering that Pexivast low dose regimen abstract?
Okay. Robert, aren't you?
I actually not know.
Well, so Dr. Chao is talking about one of the plenary sessions was on another reanalysis of Pexivast, where they had a low dose regimen of 0.5 versus 1.0, and the bottom line on it was a very good presentation. The bottom line is that low dose regimen was associated with all the bad outcomes, including higher mortality and whatnot. So suggesting that if you've got, serious, bad news, ANCA positive vasculitis, don't be skimping on the steroids. So now we're going to circle back to Yuz. And Yuz, you obviously, I did this on purpose to say that there's pushback on this and there's worry about this. Did this come up at all during the presentation?
Yes, I do. But just like to emphasize as well, before we started the low dose or versus high dose, the patient did have 3 days pulses of IV methylprednisolone. So basically, you just give them 3 IV methylprednisolone whack, and then you start oral prednisolone. But to talk about the low dose oral steroids, actually the data that supported this is the voclosporin, because they didn't start on 1 milligram per kilogram a day. They give a 3-dose IV methylprednisolone, and they give combination voclosporin, mycophenolate, and actually they start steroid on 25 milligrams. So there is a data that from clinical trials to start from that and low. But like you say, it's a personalized treatment. You also have to depend on the severity of the patient, what class of lupus nephritis, and so forth. Yeah.
Right. And I think it helps to talk to and listen to people who are experts in lupus management, because they have, just like all of you are totally wigged out and losing your mind over a lupus patient with a platelet count of 24,000, the hematologist is not even losing any sleep, not even taking your call, because the patient's not bleeding and it's not below 8,000. So, dealing with the people who deal with these problems, we do need to listen. We do need to learn. Let's move on. Dr. Reyes, what do you have from today?
Okay, so I found one of the abstracts during the plenary sessions interesting. It's abstract number 0723. So it's about biomarkers in SLE PAH. So the group by Dr. Deng from China wanted to investigate the pathogenesis of SLE PAH and identify biomarkers. And so through whole exome sequencing and GWAS, they conducted the study, and they showed that the TRAF5, or the tumor necrosis factor receptor associated factor 5, was a susceptible gene in SLE PAH. And so they found that.
Sorry, I have to interrupt. PAH being pulmonary arterial hypertension. But
yes,
go ahead.
pulmonary arterial hypertension. And so through flow cytometry of pulmonary endothelial cells, they found a significant increase in early apoptotic cells and the loss of the migratory ability of these cells when there is TRAF knockdown. And then in their mouse model, when they they saw that overexpression of TRAF5 attenuated PAH symptoms in their model. So just probably it would require future research, but it would be nice if we would have biomarkers for conditions like PAH and SLE. We know that it confers high morbidity and mortality, and maybe these could be these biomarkers can help in the diagnosis or even in treatment considerations in the future.
Yeah, this was high science, and backed up by clinical data, backed up by animal data showing really that the knockout or the ones who are going to get into trouble here. The question is, how does this going to translate to practice? And PAH is an uncommon manifestation, but a bad manifestation of lupus. So I like the approach, because I do think lupus, there are still a lot of battles to be fought, and if they can be won by this kind of investigation and identifying biomarkers, I think that patients are going to do better. You're our resident lupus expert. How did you look at this data?
Yeah, it's good data, but one thing that going to be quite hard is, I think, you need like a larger sample size, isn't it? I think it's very rare. I mean, I've hardly seen many people with severe pulmonary hypertension complications. So I think they were saying like the quotation up to potentially 15%, but we definitely certainly see less than that. And quite a lot of the pulmonary complication is more the pleural, the serositis, pleural effusion. You got your pleurisy, and sometimes you got your shrinking lung syndrome. But certainly, pulmonary hypertension is something that is quite rare. So maybe more like a sample size, and then can help with the utility, cost utility of the test. Yeah.
Yeah, you wonder if they would be able to find the same association with patients with scleroderma, for instance, which is not too far left of SLE. Let's move on. Dr. Chao, what was your big hit for the day?
Yeah, so I want to talk about abstract 0845. And this one focused on the yield of repeating assessments in chronic back pain when you're trying to assess for early axial spondyloarthritis. So I got to tell you, in my clinic, I see so many young patients who, and a lot of them are, also in the healthcare field, physicians, nurses. And I think it's a gift and a curse, right? Because we just know so much and everything that can go wrong. So, pinky hurts, maybe RA, back hurts. I read about ankylosing spondylitis, doc, help, that kind of thing. And And sometimes we go on these wild goose chases for long periods of time, trying to figure out, is this ever going to develop into AxSpA, especially in those patients with a family history, who are men, who are B27 positive, but they don't have all the distinguishing features. So this study looked at over 500 patients, and they actually followed them for, actually, obviously at the beginning, and then 3 months, 1 year, and 2 years, where they repeated their clinical assessments, inflammatory markers, and interestingly enough, imaging. And the kind of take-home message is the yield of repeating these assessments with chronic back pain and kind of looking for a new diagnosis of AxSpA was low, kind of as we expected at the 2-year mark. Interestingly enough, they just said kind of what we also expect, that what you have at baseline is probably what you're gonna keep having, and meaning not much new, at least in 2 years of follow-up. But the interesting things they found were, one, the one thing that did lead to new AxSpA diagnosis is, of course, sacroiliitis on MRI. I think that's self-explanatory, but also response to NSAIDs. Last year, pretty big study, interesting study. NSAID's not really a good predictor of inflammatory back pain, right, as we're taught in school. And then they did say overall, though, again, repeating MRIs does have a low yield unless you are a male who's B27 positive. Then you could, consider repeating MRI at a sort of annual to biannual basis.
So Robert,
go ahead, Rachel.
I was just going to ask, did they look initially at only X-rays, or did they also look at MRI, like at baseline?
Yeah, initially it was a mix of radiographs and MRIs.
Did they do STIR and T1 weighted, or
They didn't comment on that part. They didn't get. Oh, no, I'm sorry. They did. They just STIR T1 weighted. They didn't comment on that.
So I think this is an area where we underutilize the collaboration with radiology teams, and especially with the T1 weighted image, because oftentimes, and we've seen this time and time again, we have data on this, that the T1 weighted image, though it's hypo intense, right? It's a darker image, it's gadolinium enhanced. And those patients that can do GAD enhanced images, sometimes we see those protocols actually showing earlier changes in a STIR image. Now, that's not across the board, but I'm just curious as to maybe what the protocol was that they used. Yeah. And we can look at that further, but no, I think it's an interesting study.
I think definitely, if you want to, obviously get into a more kind of particular study, I think obviously a lot of room if you want to standardize those. I think there's still some controversy on AxSpA experts recommending STIR versus, what you mentioned, T1. Mm-hmm. But again, I think obviously an interesting study subject in the future.
And short time frame, right?
Who are the docs doing these assessments? Are these primary care? Or are these rheumatologists?
Oh no, these are rheumatologists at I think they used at an interesting name, space cohort in Europe, as multi-center, mostly obviously including rheumatologists here or there.
And did they have an explanation why there was difference between the gender between female and male?
Well, I think as we're mostly taught, AxSpA is still predominantly a male disease, even though the ratio is down a little bit lower from 9:1 to roughly 2:1. But I don't think they offered really an explanation into why the gender difference there.
And they were
Robert, sorry.
Go ahead, Sheila. Go ahead.
No, I was just wondering if did they only focus on back pain, or did patients, like for example, for those who developed symptoms of AS or AxSpA, did they have other symptoms other than the back pain?
No, I think this was strictly focusing on just chronic back pain symptoms. And I think, again, mainly the back pain, the inflammatory markers, and then, of course, the imaging.
Okay.
I just want to highlight something that Sheila was mentioning. The female patients in non-radiographic and AS present differently. So I think that's a limitation potentially for this study, but that may not have been what they're studying. So it's just a highlight that I'd like to bring up.
Yeah, that's a good point, Rachel, because females do present differently and less on back pain, but more on fibromyalgia and other systemic symptoms.
And that's a whole nother can of worms, though. I mean, women certainly with ankylosing spondylitis in the spa do have a different course, a different presentation, a different time in their life and whatnot. And then if you get into this consideration of non-radiographic axial spa, where they have negative x-rays, you're going to need to do an MR. The question is, do you keep doing it? And that's, I think, where there might be some wisdom from this study that could be applied to that, although that wasn't probably the intent here. But I think we've all been in a situation of more women than men, and more middle-aged than very young, who have this back pain, which has an inflammatory kind of back pain component. And you're stuck with wondering, should I be using a TNF inhibitor or an IL-17 inhibitor? Or should I do the evaluations? And I don't know that we have any firm answers on that. Anybody want to make a wild suggestion before we move on?
I mean, I always make wild suggestions. I think that was geared toward me.
Go for it.
No, I mean, I think we need to be following these patients a little bit closer. But I also, to Robert's point, the time frame of this study, going back to that, the nadir of this conversation, was 2 years. The question really becomes, is there 2-year progression? Do we see this with non-radiographic? We know these patients, if they're treated aggressively, treated early, they don't tend to move into that AS territory by classification. But I do think we are missing a portion of these patients. We still have delay in diagnoses. We still have difficulty with even reading some of our own imaging. There's a lot to learn about AxSpa, and I'm hoping the future will be clearer for us.
Yeah, I think that's a very fair statement. I think it's a challenging area, and yeah, the number of people that will evolve from non-radiographic to radiographic AxSpa is a minority. You know, it's either single digit up to 20% that will progress, but depends on how far you follow them over time. But I think that there's a wisdom in Robert's research that he pointed out today that I think does apply to other situations as well. I want to go over a session I attended this evening that I thought was kind of interesting, and it was abstract 0836, and it's about vagotomy as a means of preventing rheumatoid arthritis. The background here, as you know, is this been research initially reported by Mark Genovese a few years ago about vagal nerve stimulation leading to a reflex that is sort of inhibitory to TNF production. So it's if you will, an anti-TNF approach. And in an open label, low number patient trial, it sort of looked good. And those interventions were, in fact, real surgical vagal nerves in the neck with a lot of local complications and pathologies and Horner syndrome and bleeding and all that kind of thing. And subsequently, the companies that have worked on this trial have gone to auricular ways of stimulating the vagal nerve. And the problem is that those results have been disappointing at this point. So these researchers, who are, by the way, the same researchers who are developing this auricular nerve intervention, decided to develop some supportive data while they're doing more studies. And they looked at people undergoing vagotomy, either full truncal vagotomy or partial vagotomies, and something called super selective vagotomies, where these are being done in the abdomen, surgically, and they're being done for people and the treatment of peptic ulcer disease, right? And this was a treatment was developed back in the 1940s and is still done today, albeit not that common. And a lot of these patients are probably older. This data might even be older than the PPIs that are out there, but they had some really big numbers, and they got their numbers from the data, those Danish databases that are really rich with the quality of data that is in there. And they compared full truncal vagotomy in 2,200 patients, and compared it to a general population cohort of 22,000, so 10 to 1. And then they compared a more super selective, and the full truncal vagotomy, you're cutting the vagus nerve, there's no more vagal stimulation, right? That would be like turning off I'm sorry, or turning on a feed for TNF, if you will, right? Whereas super selective, there's still some vagal nerve activity, which is sort of like a low dose in a clinical intervention trial. The bottom line, when they compared full truncal vagotomy to the general population, they had really impressive, clearly selective increase, a selective increase in the incidence of rheumatoid arthritis over that seen in the general population. And just for comparison's sake, other patients undergoing full truncal vagotomy, they looked at the development of osteoarthritis, right, in those who had the vagotomy and those who were from the general population, and the lines were overlapping. So it clearly seemed to promote the onset of rheumatoid arthritis. And there's a bunch of other analyses that are probably not worth going into here, but this was viewed as, sort of a proof of concept that the vagal nerve could be involved. Now, some of the things that happened in this presentation was the audience said, people with peptic ulcer disease requiring vagotomies, they're probably smoking and drinking and riding motorcycles for all we know, and engaging in risky behaviors that may, but if anything, that would actually increase the odds that they would get RA in addition to this. So, maybe there could be some confounding there. People postulated that by changing the pH of the stomach, you'll be changing the microbiome, and that will be contributing. So there's a lot of things that are in play here that are interesting. And the last thing that's interesting is the same author, Dr. Baker, did the next presentation, which was the next phase of this auricular nerve stimulation. And the data that he showed was, shall I say, inconclusive, meaning not supportive of that as a treatment for rheumatoid arthritis. They're going back and they're doing more studies going forward, but this would be, again, a non-pharmacologic way of maybe alleviating rheumatoid arthritis. I thought this was exciting when it first came out. And I thought, not much of it again.
Jack, what do you think
And
Mark would say? Was he there?
He was there, and he left before I could talk to him. So I know he was there, and he's been a consultant to these people, and started some of this research back when he was still at Stanford. So I'll be interested in talking to him going forward. But I did present this because I do think this is something that you'll be possibly hearing about in the news. So, all right, let's go around and maybe get one more slice of the meeting. Let's begin with Dr. Chao.
Okay, my next abstract, 0722, by my UCSD colleague. So shout out to UCSD there. Looking at cardiovascular events in autoimmune rheumatic disease pregnancies. They actually looked at a large database, all live births in California over a 15-year span up to 2020. They noted cardiovascular events in about 2% of patients, pregnant women with rheumatic disease or autoimmune rheumatic diseases, almost 7% in pregnant women with primary antiphospholipid syndrome. And then the risk was significantly higher in pregnant women with rheumatic disease and antiphospholipid syndrome. And then the highest risk, I think the relative risk ratio was about 18, where of course expectedly in the lupus group with antiphospholipid syndrome. I think data is not too surprising, especially in the lupus and antiphospholipid syndrome category. But the one take-home message here was also the cardiovascular events, about almost a third, 30% occurred during the postpartum period. So, when we think of these pregnant patients with our diseases, we tend to follow them closely during pregnancy. I would say don't let your foot off the gas after delivery here.
So the three high risk groups, these were pregnant women who either had a rheumatic disease with antiphospholipid, lupus with antiphospholipid, but also lupus and with nephritis, but also were a higher risk there. What kind of cardiovascular events are we talking about here? Are these just venous thromboembolic events, or was it more serious than that?
I think they broke it down into I forget the exact ones they looked at, but definitely included MI. I would have to look over the exact cardiovascular events, but I don't, I think MI for sure, but I don't think they broke down the rest of the cardiovascular events here.
Right, it was, but yeah, and that was my impression as well, Robert, that it did have MI and MACE and a few others, but it was serious stuff. So, and again, these are the people we do take care of, and I think that and now the question is this real? Is this something that you see? And I think that all of us have taken care of a lot of lupus patients. I gotta say, I haven't seen that many. I've seen VTE events, but MI, heart failure, arrhythmias, I don't know. And the question is this, I mean, this is claims data, by the way. This was not a prospective study. This is claims data done by Tina Chambers from UCSD. And she's like the master at this kind of data and analysis. So I don't know. I'm my only caveat is I'm concerned about why have I not seen any of this? And I've certainly seen plenty. Anybody else have any other can support this kind of concern or argue against it?
Yeah, so I think similar to your experience as well, Jack. I've not seen many major cardiovascular events like shortly postpartum in a woman with lupus. I'm just wondering, Robert, in the abstract, did they discuss whether this patient did they have underlying cardiovascular disease like before they deliver babies?
No,
I didn't.
they did not. No. All right, Rachel, what's your big hit? Little hit.
I have
I'm sorry.
two. No, little hit. So I will, I'm not going to piggyback off Robert like I told everybody I was going to do. Dr. Pooja Mehta, this is not an abstract. This was a really great lesson. This was one of the sessions today. She did a session on imposter syndrome. And I don't know about you guys, but I've definitely had imposter syndrome. It's possible I still have some. And she, in her take-home messages, had 3 things that we need to work on. We need to reflect. We need to have an accountability buddy. Don't try to take it on by yourself. Check your values, check your actions, hold on to your hope, and then mobilize. So get out there, get doing things, go to the gym, change your character in a way that you don't question your judgment anymore. Just take some time away from that. But the most valuable point was to create. Flip your bias, check out what you're doing. And then the best point that she made, which is her main take home, was improve yourself and the people around you, and do that with love, which is what I think is the crux of what we do at Room Now. And it just hit home for me. And this is a prime example.
Yeah, I mean, I do think this is a big problem for a number of people, and I want to say it might even be related to burnout in some people as well. It's good to have this sort of counsel on this, because it doesn't seem like it's restricted to a young person or a middle-aged person or a successful person or I think it affects the wealthiest and the most successful and the newest and the brightest. So it might be a good listen for people to get a hold of that presentation. I believe that's one of the ones that is going to be on demand, probably the week after the meeting, that you could listen to that. Yuz, do you have a quick hit that you want to review for the audience?
Yep. So I don't really like to talk about my project, but it's just because I got so much attention today in my posters, and there's been tons of people over there.
Please do.
Yeah. So so the abstract is 0548. So this is looking at the people with ANA positive with the diagnosis. So the aim really for this study is to help the rheumatologists when you were first referred by primary care, fresh, whether is there any prediction tool that can help you exclude those with non-autoimmune pathology. For example, if you do get like someone referred with acne and ANA, then I think that's quite easy to say, well, you don't have lupus, and you can quite safely discharge them. But those people that come with arthralgia, I got a little bit of rash a few months ago, maybe a bit of fatigue. So some rheumatologists find it difficult because they tend to do just watch and observe, strategy, and this is not cost effective really. So if we got a good tool, then that will be helpful. So what we've done is we've recruited all these newly referred ANA positive from the primary care. There were 148 patients altogether, and we look at a few clinical and also interferon biomarkers. What we found, so this is actually 3 analysis. So we found at what year 1 and also year 3, there were 3 important markers. One is the baseline higher interferon score. Secondly is if you have a family history of first degree relative of any autoimmune rheumatic and musculoskeletal diseases. And also the third one, if you have a higher number criteria. So if you do all this combine biomarkers, the area under the curve actually become 0.89. So it's really good. And also importantly, you need a test or a tool which is high specificity. So in this one, if you use combined marker, the specificity is 98%. So basically it's good. This is now undergoing validation. So we just finished the cohort validation, which hopefully can present in the next 1 or 2 years. And if this proven to be true, these 3 markers, hopefully we can then use that in practice. That you say, right, use this at first presentation, we can safe discharge. And importantly, the thing is, if those people who are in the high risk score, those are the ones that I wanted to do an early intervention trial, because they are at high risk, and then you can then design a trial, placebo against a therapy and see whether they progress or not. Yeah.
All right, so you're talking about 2 separate things there. Let's just throw out the high risk group. That's sort of a pre-lupus kind of story that we're not going to get into.
Yeah.
Here, where the audience is interested in your ANA referral story, but you've made it difficult for them trying to find a biomarker that they don't have, or trying to find. What about just using other more specific tests like double-stranded DNA?
Yeah, so that's a good question. So we had to look at the titer, the various range of antibodies, and whether you do accumulation, if you count how many antibodies positive, and none of them were actually predictive of progression. So that's why we do need all this. Yeah, and I do agree in terms of practicality, whether it's availability. So the next, the current project as well is actually we are looking into like proteomics. And because proteomics is quite easy to measure, and if this is compatible to the interferon score that we've got, and hopefully this is more accessible and it can easy to use for practice. Yeah.
I'll voice a little tidbit of support in what you're going through here. We all want to just say, ANA positive. Don't worry, lady. None of these people, like you, will ever have lupus. And I see 1,000 consults like this. And I'm not even going to reappoint you back. But when I was doing research with the Baylor Research Institute, collecting mRNA samples and doing microarrays to classify patients immunologically with Virginia Pasquale, when there's a certain pattern of gene expression that's very typical for lupus, and a different pattern very typical for Still's disease, which I was very interested in. But the lupus patients had a very distinctive pattern. And when I use controls, osteoarthritis, gout, fibromyalgia, ANA positive referrals, the ANA positive referrals that did not have criteria and were told to go away, 5% of them had a microarray signature that looked just like lupus, suggesting that, maybe you want to keep your eye on that person. Maybe they have. So anyway, there is something there. And I think a a good clinical battery along with a biomarker that may not be so hard to get would be a welcome addition to anybody's practice. Sheila, your last research report for today?
I think I wanted to highlight a session earlier about CNS vasculitis. Dr. Haj Ali gave a very good discussion about CNS vasculitis and just some take-home points where or clinical pearls, as she mentioned, that CNS vasculitis clinical diagnosis is really difficult because it can present with a lot an array of clinical features. And always do CSF analysis because it is essential in the diagnosis, and it can rule out other entities like infections. And non-vascular imaging is highly sensitive. And brain biopsy is valuable, especially if you're considering an alternative diagnosis. So just to point out, one of her clinical scenarios where intravascular lymphoma mimicked angiographic findings seen in CNS vasculitis. So another take-home point there is that, you revisit a diagnosis of CNS vasculitis if your patient on steroids or cyclophosphamide is really not responding, or initially responded but went to relapse immediately. And so consider doing a brain biopsy, which is, according to her, is also underutilized but has prognostic value in it.
Okay. Yeah, these are challenging patients, and to have a clear-cut way to consider and evaluate is really the way to go. I must say that I have to look it up and or give a call to the Cleveland Clinic to get my clinical algorithm back into shape when I am presented with these cases. I'm going to end with a reminder to the audience that there were two reprise presentations that are slightly different than what was shown at EULAR. One is abstract 0835, the APIPR study, shows up again, Dr. Andrew Cope and colleagues looking at preclinical RA, 100 patients that were treated with placebo, 100 patients treated with abatacept 125 weekly, followed for a year. And clearly that worked in preventing the development of RA. And when they stopped the drug at 1 year and followed them another year, it looked like it delayed the onset of RA, unless, of course, you looked at people who had extreme serologic activity, very, very high titers of ACPA, or multiple autoantibodies. Those lines never came together, suggesting it still was preventative. So preventative, delayed, it's hard. It's an interesting story. It's a repeat story for the potential value of abatacept. Well, I'm not sure where that's going to go. The other one that shows up again, that's a real head scratcher, but really noteworthy, is abstract 0839, a Chinese study about TLL-018, a combined JAK1/TYK2 inhibitor when given to RA patients. And it's a 4-arm trial with a 12-week endpoint. They either get standard dose tofacitinib, 5 BID, versus 10, 20, or 30 milligrams of this TLL-018. And looking at an ACR 50 outcome, you would expect with any great therapy about a 40% ACR 50 outcome. That's exactly what tofacitinib showed. And that's also what the low dose of TLL-018 showed. But the two higher doses, 20 and 30, oh my God, it was like 60 and 70%. It was really, really high. And the question is why? And no one can explain why this would happen. Fairly well tolerated. Again, they just started a new phase 3 trial in biologic DMARD incomplete responders. It's going to be done in China again. Maybe we'll see that next year, but that's a real head scratcher. And I mean, really breaks through the ceiling on responses in what should be refractory RA. All right, folks, I hope you enjoyed this as much as we did. Tune in tomorrow for day 2 daily recap, again with our Room Now faculty. These guys get a break, and we're going to bring in a whole new crew of 4 or 5. So Robert, Sheila, Yuz, and Rachel, thank you.
Thanks.
Thank
Thank
you.
you.
All right, bye-bye.